everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I will be discussing a very important topic, that is sarcoidosis. So sarcoidosis, it is a disorder where you have the presence of a non-caseating granuloma. And this particular sarcoidosis, it is a disorder with multisystem involvement. And in these individuals, what exactly is the cause is not known. But what will be the characteristic histological feature? The characteristic histological feature, it is characterized by the presence of non-specific, non-caseating granulomas. And where do you have this non-caseating granulomas? These non-caseating granulomas, they are accumulated in the various systems in our body. But most commonly, the organ which is affected is lung. And the presence of non-caseating granuloma along with bilateral hilar lymphadenopathy, right? So along with this non-caseating granuloma, if there is presence of bilateral hilar lymphadenopathy, then it is strongly suggestive of the sarcoidosis. So sarcoidosis is a disorder where you have the presence of non-caseating granuloma in the various organs. Now, what is this sarcoid granuloma made up of? So basically, this sarcoid granuloma, it is formed as a part of the inflammatory process. So the inflammatory process in sarcoidosis is the one, right? The inflammatory process in the sarcoidosis is the one which is responsible for the development of the sarcoid granuloma. Now, what does this sarcoid granuloma contain? This sarcoid granuloma, it contains the giant cells, right? The granuloma contains the giant cells. What are giant cells? It is nothing but the accumulation of the macrophages together, they form what is called the giant cell. So this granuloma, it is made up of the giant cell. And you should know what is this particular type of giant cells in this sarcoid granuloma. That contains Langerhans giant cells or the foreign body variety, right? Langerhans giant cells or foreign body variety of the giant cells. And these giant cells, they contain or they often contain the inclusion bodies, right? They often contain the inclusion bodies. So inclusions which are seen in the giant cells in sarcoidosis are as follows. So please remember this mnemonic, that is SAR, right? Please remember this mnemonic SAR. So in sarcoidosis, you take the first three letters. The word S stands for Schaumann bodies. The word A is asteroid bodies. And the word R is residual bodies. Right. So this is what is the inclusion bodies that you will have in patients with the sarcoid granuloma. Now, if you take the prevalence of this sarcoidosis, there is increased incidence of sarcoidosis among blacks compared to that of whites. And if you see the age group at which you will have this sarcoidosis, most commonly the age group which is affected is around 2nd to 4th decade of life, that is in between 20 to 40 years of the individual. And I have said you in the beginning itself that sarcoidosis is a disorder where you have a multisystem involvement. And you should know the very important multiple choice question, that is the most common organ which is affected. Right? The most common organ involved in sarcoidosis is lung. So within the lung, you have the presence of this inflammatory reaction, that is non-caseating granuloma, along with the presence of bilateral lymphadenopathy. Now, let me tell you what exactly are those pulmonary manifestations. So, if you take the pulmonary manifestations, or among all the organs which are being affected in sarcoidosis, 90% of it is the lung involvement in sarcoidosis. And it is characterized by the presence of interstitial lung disease. Right? It is characterized by the presence of interstitial lung disease. So, because of the presence of this interstitial lung disease, in patients with sarcoidosis, when you do a pulmonary function test, that will show you a restrictive pattern. And next important thing is the pleural involvement. So, the pleural involvement is seen in around 1 to 5% of cases. Right, it is seen in around 1 to 5% of cases. And even there can be also development of cavitation. And this cavitation is rare in patients with the sarcoidosis. So that will be the pulmonary manifestations that you will have in patients with sarcoidosis, and the most common organ affected will be the lung. And the next important structures which are affected in sarcoidosis is the lymph nodes. And lymph node involvement is around 75 to 90%. Right, lymph node involvement is around 75 to 90%. And please remember, the hallmark of sarcoidosis is the presence of bilateral hilar lymphadenopathy. Right, bilateral hilar lymphadenopathy. That is a characteristic feature or the hallmark in patients with the sarcoidosis. And not only that, there will be also parotid enlargement. Right, so due to accumulation of non-caseating granuloma, there is also parotid gland enlargement that you will see in patients with the sarcoidosis. Then, followed by that, the skin involvement. Skin involvement will be in the form of the erythema nodosum. Now, yes, so this is your erythema nodosum. So, erythema nodosum is the disorder where most commonly the affected part of the skin is in the lower limbs, right, where you have the inflammation of the subcutaneous fat. And another important cutaneous manifestation you will have in sarcoidosis is lupus pernio. Right, lupus pernio. So, what will be the features in lupus pernio? You will have the presence of purple blue shiny swollen lesions on the nose and as well as cheek. So you can observe that here. Purple blue shiny swollen lesions over the nose and as well as the cheek. Right, over the nose as well as the cheek and on ears. So this will be your lupus pernio. Now, after having discussed about the cutaneous manifestations, you take the other manifestations. In the eye, the manifestations of sarcoidosis will be in the form of uveitis, right, where there is inflammation of the uvea. And the kidney involvement, if you see, that is the renal involvement, that will be in the form of the renal hypercalcemia. And this renal hypercalcemia, right, this renal hypercalcemia, it is with or without hypercalciuria. And skeletal manifestations. or in the form of arthritis. And nervous system involvement will be in the form of peripheral neuropathy. Right, nervous system involvement will be in the form of peripheral neuropathy. And cardiac involvement, if you see, that is in the form of cor pulmonale. Okay, so these are the other systems which are affected in sarcoidosis apart from your lung, lymph nodes and skin. And in all these, it is mainly because of the inflammation and formation of non-caseating granuloma. And let me tell you, the inflammation, it is mediated by T lymphocytes. Right, it is mediated by T lymphocytes. Okay, next, having discussed about the clinical manifestations, so as the multisystem involvement is there, similarly the clinical manifestations also will be there. Like for example, if the individual is having interstitial lung disease in the pulmonary involvement, the individual will have difficulty in breathing, right, and they'll have dry cough. And pleural involvement is there in the form of pleural effusion, and again there will be gradual onset dyspnea. And skin involvement, right, you have erythema nodosum where you can have pain within the skin within the lower limbs. And eye, you have uveitis where you can have the impaired vision. And renal impairment is there, and arthritis, there will be pain within the joints. Peripheral neuropathy, and that will be in the form of tingling, numbness, paresthesias in the extremities, distal part of the extremities. And cardiac involvement, if you see, that is in the form of the cor pulmonale. And that cor pulmonale, mainly the individual will have right heart failure features, right, where there will be raised JVP, tender hepatomegaly and pedal edema. So depending upon which particular system is involved, accordingly you will have the manifestations in patients with the sarcoidosis. And you see the workup. Workup, if you see, when you do a complete blood picture, that will show you the presence of leukopenia. And there will be elevated ESR because it is an inflammatory disorder. So the ESR is being elevated. And there will be also hypercalcemia. And this particular hypercalcemia, it is present in only around 5% of patients. And there can be also hypercalciuria as well. But another important blood workup is the ACE levels. That is angiotensin converting enzyme levels. They are elevated in almost 40 to 80% of patients. Right, they are elevated in almost 40 to 80% of patients with active disease. Right, this is very important. Mainly in patients with active disease, the ACE levels are elevated in almost around 40 to 80% of individuals. Now, if you take this angiotensin converting enzyme, you should know why it is being elevated in sarcoidosis. Let me tell you, the cells in the granuloma, right, the cells in granuloma, they are the one, they will release the angiotensin converting enzyme in the serum. Right, they are the one that will release angiotensin converting enzyme into the serum. And that is the reason why the ACE levels are being elevated. And ACE levels indicate the activity of the disease. Right, ACE levels indicate the activity of the disease as well. And not only that, ACE levels provide an important method of monitoring the course of activity. Right, it also helps in monitoring the course of activity. Okay, so that is what is your ACE, that is angiotensin converting enzyme. Next, followed by the workup on the blood. The next important investigation you need to know is the chest X-ray in patients with the sarcoidosis, right? This is a very important investigation. And what does this chest X-ray shows? See, almost 90% of patients with sarcoidosis, they have this abnormal X-ray, right? They have the abnormal chest X-ray. And what is that abnormality? See, in sarcoidosis, the abnormality in the lung, it is primarily in the form of an interstitial lung disease, where you have what is called interstitial pattern within the lung. Right, where you have the presence of interstitial pattern within the lung. And you can also observe cavitation, but we have discussed that in the beginning itself that it is rare. And this cavitation, it is present in less than 5% of patients with sarcoidosis. And another very important finding in the chest X-ray is the presence of bilateral hilar lymphadenopathy. Right, presence of bilateral hilar lymphadenopathy. So accordingly, we have three classic X-ray patterns of the pulmonary sarcoidosis. That is, we have type 1, type 2 and as well as type 3 pulmonary sarcoidosis. In type 1, the individual will have bilateral hilar lymphadenopathy with no parenchymal changes. Right, with no parenchymal involvement. That is your type 1 form of the pulmonary sarcoidosis. Whereas type 2, if you see, you have bilateral hilar lymphadenopathy. Along with that, the individual will also have diffuse parenchymal changes. Right, the individual will have diffuse parenchymal changes. Whereas in type 3, the individual will have diffuse parenchymal changes right, there is diffuse parenchymal involvement, but there is no hilar lymphadenopathy. Right, there is no hilar lymphadenopathy. That is what will be the X-ray pattern in the pulmonary sarcoidosis, type 1, type 2 and as well as type 3. Now, in case of this pulmonary sarcoidosis, you have to remember one important triad that is called as the Garland's triad. Now, this Garland's triad, this is also known as, right, this is also known as 1, 2, 3 sign. Now, what is this 1, 2, 3 sign and what is this Garland's triad? In these individuals or patients with sarcoidosis, when you take a chest X-ray along with bilateral hilar lymphadenopathy, right, along with bilateral hilar lymphadenopathy, there will be also involvement of right paratracheal nodes. Right, there will be involvement of the right paratracheal nodes. This is what is called as the Garland's triad or 1, 2, 3 sign. And another name for this Garland's triad or 1, 2, 3 sign is that it is also called as the pawnbroker's sign. Right, this is also called as the pawnbroker's sign. So that is what is your Garland's triad or 1, 2, 3 sign or pawnbroker sign, where you have bilateral hilar lymphadenopathy. Along with that, there will be enlargement of your right paratracheal lymph nodes. Then, followed by that, the another important investigation is CD4 to CD8 ratio. Now, if you take a patient with active sarcoidosis, Right? If you see the patients with active sarcoidosis, it results from an exaggerated cellular immune response. Right? There will be exaggerated cellular immune response. Now, because of this exaggerated cellular immune response, this will result in the accumulation of large number of CD4 cells in the affected organs. Right? So there will be accumulation of large number of CD4 cells in the affected organ. Right? So thereby what will happen to your ratio? CD4 to CD8 ratio, it is in a range of 10:1. Right? CD4 to CD8 ratio, it may be as high as 10:1. So please remember this point. This CD4 to CD8 ratio, whichever is increased, it is seen in the affected organs. Right? Whereas this increase in CD4 to CD8 ratio, it is not seen in the blood. Right? It is not seen in the blood. Right? It is seen in the affected organs. Then, next important investigation is Queen-Silsbach test. Now, what is this Queen-Silsbach test? What you have to do in this Queen-Silsbach test is that you have to prepare a tissue, right? A specially prepared tissue. Right? A specially prepared tissue, and this specially prepared tissue is derived from the spleen of, right? Derived from the spleen of affected patient with sarcoidosis. Those individual who is suffering with the sarcoidosis, from the spleen of that individual, you take out some tissue. And this particular tissue which has been extracted from the spleen of the affected sarcoidosis patient have to be injected intradermally. Right? That is into the skin. Okay, so it is injected intradermally into the skin of the patient in whom you are suspecting sarcoidosis. Right? Intradermally in patients in whom you are suspecting sarcoidosis. Now in this individual in whom you have injected this specialized tissue, you take a biopsy. Right? You take a biopsy after 4 to 6 weeks of injection. Right? You take a biopsy after 4 to 6 weeks after the injection. Now, for suppose if this biopsy shows the presence of non-caseating granuloma, right? If this biopsy shows the presence of non-caseating granuloma, then it is highly specific for the diagnosis of the sarcoidosis. That is what is your Queen-Silsbach test. This is only of historical importance. We are not doing this, but from academic point of view, you can be asked a multiple choice question from this Queen-Silsbach test. Next, the another important test is gallium-67 uptake. So you have to inject this particular gallium-67, and this gallium-67, there will be increased uptake into the lacrimal glands and as well as the parotid glands, and accordingly you have the development of the lambda sign and as well as the panda sign. Let me discuss that in detail. So you take this lambda sign, right? If you see this lambda sign, Lambda sign is formed from increased uptake in bilateral hilar lymph nodes and right paratracheal lymph nodes. Okay, you can see that here. So this is your right hilar lymph node, and this is your left hilar lymph node, and this is your right paratracheal lymph node. So to these lymph nodes, when the gallium-67 uptake is there, then in the imaging it will appear in the form of a lambda. That is why it is called lambda sign. Then you take panda sign. See, if you take this panda sign is formed from increased uptake in the lacrimal glands. So you can observe that here, right? Increased uptake in the lacrimal glands. So when you take an imaging of gallium-67 in patients with sarcoidosis, so there will be increased uptake into the lacrimal glands, and that will appear similar to that of the eyes of a panda. So that is the reason why it is called panda sign. Okay, and another important point, the degree of uptake of gallium-67, it completely depends upon the activity of the disease. So please remember this point. So the degree of uptake it completely depends upon the activity of the disease. Right, it completely depends upon the activity of the disease. Okay, next. And next important investigation is biopsy. So definitely the investigation of choice will be your biopsy. Now, what does this particular biopsy show you? Let me tell you, biopsy is mandatory to make a definitive diagnosis of the sarcoidosis, and that will show you the characteristic non-caseating granuloma. Right, that will show you the presence of a characteristic non-caseating granuloma. And another important investigation will be pulmonary function test. What does this pulmonary function test show? Pulmonary function test show you the presence of restrictive pattern. So restrictive pattern in the sense where FEV1 by FVC will be either normal or increased, right? So that will be the pulmonary function test in patients with the sarcoidosis. Now, followed by that, you see, this is the summary of the investigations. So what will happen to your ACE levels? It is increased. And what does the X-ray of the chest show? Presence of bilateral hilar lymphadenopathy. The skin test is nothing but your Queen-Silsback test. Gallium-67 uptake will be there. And biopsy is the one definitely confirms the sarcoidosis. And yeah, so this is the summary of investigation in patients with sarcoidosis. Then if you see the treatment, what is the drug of choice? The drug of choice will be the corticosteroid, that is prednisolone. And how much of prednisolone should be given? That should be given in a dosage of 0.5 to 1 milligram per kg per day. Right, 0.5 to 1 milligram per kg per day. So the indications for steroids is that you have to give when the individual is having the lung involvement, that is in the form of the interstitial lung disease, right, and the other system involvement as well, like for example uveitis, that is the individual has the development of iritis, then arthritis, right, where when you give steroids the pain of the joints will get subsided. And in CNS involvement also, that we call it as neurosarcoidosis, right, where the patient can present with the seizures or altered sensorium, right. Myocardial sarcoidosis, that is if there is cardiac involvement also, you need to give the steroids. And even granulomatous hepatitis, right, even granulomatous hepatitis, you have to give this particular steroids. And not only that, the skin involvement, the cutaneous involvement in the form of erythema nodosum. So these are all the scenarios where you need to give steroids, and long-term therapy is usually required over months to years, right? So you have to give the steroids for months to years. And these are all the indications where you have to give the steroids. Next, followed by that, in a case of corticosteroid refractory disease. So in corticosteroid refractory disease, you need to give the immunosuppressant drugs. And these immunosuppressant drugs include, number 1, methotrexate. And second, azathioprine. And third, infliximab. So these are the immunosuppressants that we give in corticosteroid refractory scenarios. Okay, or you should use these particular immunosuppressants where the individual is intolerant to the steroids. Right, where the individual is intolerant to your corticosteroids. Okay, so these are the scenarios where you need to give methotrexate, azathioprine or the infliximab. Now, if you see the prognosis in these patients with sarcoidosis, there are certain good prognostic signs. Now, what are those good prognostic signs? Like for example, if there is hilar lymphadenopathy alone, right, if there is hilar lymphadenopathy alone, and if you give steroids, the outcome or the prognosis is good. But please remember, if there is also lung parenchymal involvement, then the prognosis is worst. Okay, so along with the hilar lymphadenopathy, if there is lung parenchymal involvement, and this lung parenchymal involvement, already I have said you, that will be in the form of interstitial lung disease. So if there is lung parenchymal involvement also, then the outcome is not good. Right, the individual has the worst prognosis. And another important good prognostic sign is presence of erythema nodosum. Erythema nodosum, it portends a good outcome. Next, followed by the prognosis, what will be the pulmonary complications and cardiac complications. So about 20% of patients with lung involvement, they suffer irreversible lung impairment. Right, they will have irreversible lung impairment. And this irreversible lung impairment, it is characterized by progressive fibrosis. Right, it is characterized by progressive fibrosis. There can be bronchiectasis. Right, and there can be cavitation. So these are the irreversible lung impairment signs. And as the severity of the disease increases, that is in advanced stage, right, that is in advanced stage of sarcoidosis, the individual can develop pneumothorax. Right, and second important, there can be hemoptysis. Okay, so these are the long-term complications in advanced stage. And finally, you should know what is the cause of death in patients with sarcoidosis. Death occurs from respiratory insufficiency. Right, and this respiratory insufficiency occurs in about 5% of patients. And what are the cardiac complications in sarcoidosis? Cardiac complications, that will be in the form of myocardial sarcoidosis. And this myocardial sarcoidosis, it is seen in almost 5% of patients. Right, and sometimes this will also lead to the development of restrictive cardiomyopathy, or there can be development of cardiac arrhythmias. Right, there can be development of cardiac arrhythmias, and next there can be even conduction disturbances. Right, there can be even conduction disturbances. So these are the cardiac complications that you will have in patients with the sarcoidosis. So with this, I'm done with the topic of sarcoidosis. To summarize, sarcoidosis is a disorder characterized by non-caseating granuloma, and if there is presence of bilateral hilar lymphadenopathy, that is strongly suggestive of sarcoidosis. Lung involvement is the most common organ which is affected in sarcoidosis, and lung involvement is in the form of interstitial lung disease, and the other organs which are affected apart from lung is your involvement of eye, involvement of skin, that is in the form of lupus pernio. There can be bilateral hilar lymphadenopathy, right? So these are like multiple organs which are affected, even heart in the form of myocardial sarcoidosis, and CNS involvement in the form of neurosarcoidosis. So it's a multi-system involvement, and the definitive diagnosis will be your biopsy. Drug of choice will be your steroids. So with this, I'll wind up this session of sarcoidosis, and thank you very much.